Acute Bacterial Rhinosinusitis. Introduction. Distinguishing a common cold, viral rhinosinusitis from acute bacterial rhinosinusitis, though not easy, is important. In acute bacterial rhinosinusitis, symptoms of viral rhinosinusitis after several days suddenly start worsening instead of slowly improving. Microbiology. Acute bacterial rhinosinusitis is a common condition caused by bacterial infection of the paranasal sinuses. Most common bacteria. The three bacteria that account for the vast majority of cases of acute bacterial rhinosinusitis in both adults and children are Streptococcus pneumoniae. This bacterium is commonly found in the upper respiratory tract and can cause pneumonia, meningitis, and sinusitis. It's responsible for 30 to 40% of acute bacterial rhinosinusitis cases. Haemophilus influenza. This bacterium is also commonly found in the upper respiratory tract and can cause pneumonia, meningitis, and sinusitis. It's responsible for 20 to 30% of acute bacterial rhinosinusitis cases. Moraxella catarrhalis. This bacterium is less common than the other two, but is still a frequent cause of acute bacterial rhinosinusitis, particularly in children. It's responsible for 10 to 20% of acute bacterial rhinosinusitis cases. Other bacteria. Apart from the three most common bacteria, other bacteria that can cause acute bacterial rhinosinusitis include anaerobes. These bacteria are capable of growing in the absence of oxygen and are commonly found in the mouth and throat. They include species such as Prevotella, Porphyromonas, and Fusobacterium. Streptococcal species. Apart from Streptococcus pneumonia, other streptococcal species, such as Streptococcus pyogenes and Streptococcus mitis, can also cause acute bacterial rhinosinusitis. Staphylococcus aureus. This bacterium is commonly found in the skin and can cause a range of infections, including sinusitis. Predisposing factors. Acute bacterial rhinosinusitis is a condition caused by bacterial infection of the paranasal sinuses. While bacteria are the primary cause of acute bacterial rhinosinusitis, several predisposing factors can increase the risk of developing this condition. Here are the most common predisposing factors for acute bacterial rhinosinusitis. Viral rhinosinusitis. Viral rhinosinusitis, commonly known as the common cold, is a viral infection that can predispose individuals to acute bacterial rhinosinusitis. The inflammation and swelling caused by the virus can block the sinus openings, leading to the accumulation of mucus and bacteria. Allergic rhinosinusitis. Allergic rhinosinusitis is a condition characterized by an allergic reaction to environmental allergens such as pollen, dust, and mold. The inflammation caused by the allergic reaction can block the sinus openings, leading to the development of acute bacterial rhinosinusitis. Trauma. Trauma to the face, nose, or head can lead to the development of acute bacterial rhinosinusitis. Fractures or dislocations of the bones in the face or nose can disrupt the normal drainage of the sinuses, leading to the accumulation of mucus and bacteria. Physical stigmata. Structural abnormalities in the nasal cavity, such as a deviated nasal septum, can increase the risk of developing acute bacterial rhinosinusitis. These abnormalities can obstruct the sinus openings and prevent proper drainage of the sinuses. Swimming and diving. Swimming and diving can also predispose individuals to acute bacterial rhinosinusitis. Infection can occur when contaminated water enters the sinuses through the openings. High levels of chlorine in swimming pools can also cause chemical inflammation in the sinuses, leading to acute bacterial rhinosinusitis. Barotrauma. During air travel or scuba diving, barotrauma is a condition that occurs when there is a change in pressure between the inside and outside of the sinuses, leading to the development of acute bacterial rhinosinusitis. Dental infections and extraction. Dental infections and the extraction of upper molars and premolars can also predispose individuals to acute bacterial rhinosinusitis. Infections in the teeth can spread to the maxillary sinus, leading to the development of acute bacterial rhinosinusitis. During extraction, the root of a tooth may be pushed into the maxillary sinus, increasing the risk of infection. Pathology of acute bacterial rhinosinusitis. Acute bacterial rhinosinusitis is characterized by inflammation of the mucosa, leading to several pathological changes. The following are the main features: hyperemia and exudation of fluid. The inflammation of the mucosa causes an increase in blood flow to the area, leading to hyperemia. This, in turn, causes exudation of fluid from the blood vessels into the surrounding tissue. Outpouring of polymorphonuclear cells. In response to the bacterial infection, the body sends polymorphonuclear cells to the affected area to fight off the infection. These cells are responsible for the pus formation in the sinuses. Increased activity of serous and mucus glands. The inflammation also causes an increase in the activity of the serous and mucus glands in the sinus lining, leading to increased secretion of mucus. Destruction of mucosal lining. The mucopurulent exudate that forms in the sinuses can cause destruction of the mucosal lining, leading to further inflammation and irritation. Empyema of the sinus. If the ostium opening of the sinus becomes blocked, the pus cannot drain out of the sinus, leading to empyema, collection of pus in the sinus. This can cause destruction of the bony walls of the sinus. Fulminating dental infections. Dental infections that cause acute bacterial rhinosinusitis can progress rapidly and be very severe. Factors affecting the progress of the disease. The progress of acute bacterial rhinosinusitis depends on several factors, including virulence of organisms. The virulence, ability to cause disease, of the bacteria involved can influence the severity and duration of the infection. Defense system of the host. The immune system of the infected person plays a critical role in fighting off bacterial infection. Structural features of osteometal complex. The osteometal complex is a group of anatomical structures that regulate the drainage of the sinuses. Any structural abnormalities in this area can lead to blockage and subsequent infection. Clinical features. Acute bacterial rhinosinusitis is a condition where acute inflammation of the mucosa causes various symptoms. Acute bacterial rhinosinusitis follows fewer than 5 in 1,000 colds. Symptoms of upper respiratory tract infection lasting for more than 10 days or worsening after 5 to 7 days may indicate acute bacterial rhinosinusitis. Predictors of acute bacterial rhinosinusitis. The best predictors of acute bacterial rhinosinusitis that differentiate it from viral rhinosinusitis include maxillary toothache, poor response to decongestants, colored, purulent nasal discharge, abnormal transillumination. Other predictors include unilateral facial pain and mildly elevated erythrocyte sedimentation rate. Findings with little predictive value include headache, difficulty in sleeping, sore throat, sneezing, malaise, itchy eyes, fevers or sweats, and painful chewing. Severe symptoms include both high-grade fever and purulent nasal discharge for 3 to 4 consecutive days. Symptoms description. Rhinorrhea, nasal discharge, may be thick, thin, clear, or purulent. Cough may remain throughout the day and may be more at night. Headache usually appears on waking, gradually increases, peaks about midday, and then subsides, also known as office headache. Ethmoidal pain, aggravated by movements of the eyeball, is localized over the bridge of the nose, medial and deep into the eye. Halitosis, paraorbital edema, and nasal congestion may be present. Additional adult features may include facial pain, headache, and dental and gum pain, especially in maxillary sinus involvement. Pain may be aggravated by stooping, coughing, or chewing. Nasal examination. Nasal examination may reveal edema, hyperemia, and purulent debris. The most specific feature is purulent exudates in the middle meatus. Non-specific features are facial tenderness on palpation over sinuses or the maxillary teeth. Postural test. If no frank pus is seen in the middle meatus, a postural test is performed. Method: middle meatus is decongested with a pledget of cotton-soaked and topical decongestant. The patient is instructed to sit with the affected sinus turned up. Purulence in the middle meatus may be seen after 10 to 15 minutes. Acute Bacterial Rhinosinusitis. Investigations. Transillumination test. It's performed in a dark room using a bright light. The affected sinus is found opaque. For maxillary sinuses, the light is placed along the cheekbone, and light transmission is compared over maxillary sinuses. For frontal sinuses, light is placed in the superior medial corner of the anterior orbit. Frontal sinuses often develop asymmetrically. Interpretations: normal, typical light transmission; dull, reduced light transmission; opaque, no light transmission. Nasal endoscopy examination. The brighter illumination, magnification, and angled view of endoscopes, sinoscopes, facilitate examination of all the cleft and crevices of nose and nasopharynx. Indications. Sinoscopy facilitates in diagnosing the nose, paranasal sinuses, and nasopharynx diseases. Locate the site of nosebleeds, polyps, and discharge. Biopsy from nose, paranasal sinuses, and nasopharynx lesions can be taken. Assess the response to treatment of nose, paranasal sinuses, and nasopharynx diseases. Position of patient. Patient is kept in either sitting or supine position. Techniques. Anesthesia. Mix 4% xylocaine in equal quantity of oxymetazoline hydrochloride. Instill these drops into the nose, and then pack nasal cavity with packing impregnated with this solution. Method. For thorough and complete examination, the scope is passed through the standard 3 paths. The examination is conducted while inserting and withdrawing the scope. First pass. 0-degree sinuscope. It examines the nasal vestibule, a nasal cavity in general, the septum, the inferior meatus, and the nasopharynx. The scope is passed up to the nasopharynx through the inferior meatus. Slight pressure over the lacrimal sac may show the opening of the nasolacrimal duct in the inferior meatus. Note the septal deviation or spur, the nature of nasal discharge, and the color of the mucous membrane, the opening of the eustachian tube, the walls of the nasopharynx, and the upper surface of the soft palate. Second pass. 0-degree sinuscope. It examines the posterior part of the middle turbinate, sphenoethmoidal recess, superior meatus, superior turbinate, and openings of the sphenoid sinus, in the posterior wall of the sphenoethmoidal recess between the nasal septum and superior turbinate, and posterior ethmoid sinuses, in the superior meatus. The scope is passed medial to the posterior part of the middle turbinate and progresses up to the sphenoethmoidal recess between the nasal septum and superior turbinate. Third pass. 30-degree sinuscope. It examines the osteometal complex in the middle meatus, such as uncinate process, bulla ethmoidalis, hiatus semilunaris, sinus of turbinate, space lateral to middle turbinate, and the frontal recess. The sinuscope is passed into the middle meatus, usually from the anterior aspect, but in some cases it's entered from behind, where it's wider, and the structures are examined from behind forward. If needed, middle turbinate can be gently retracted medially with the help of freer elevator. Computed tomography imaging. Indications include refractory and recurring cases of acute bacterial rhinosinusitis and suspected cases of complications to determine the extent of orbital, bony, and central nervous system involvement. Computed tomography is done after the completion of the antibiotic course. The findings may include obstruction of osteometal complex, polypoid changes, and bony abnormalities. Plain sinus X-rays are now not recommended. A limited sinus CT scan, coronal sections only, provides excellent imaging detail. It cuts 50% of radiation exposure. New low-dose CT scanners have only 10 to 15% of radiation exposure. Red flag findings are unilateral disease, sinus expansion, and bony erosion. Abnormal findings are sinus opacification, air fluid level, marked mucosal thickening, and polyps. Findings not generally concerning are small retention cyst, concha bullosa, and minimal mucosal thickening. Antral puncture. Aspiration of fluid from the sinus is done for the identification of infecting organisms. Gram staining, culture, and sensitivity are done especially in refractory cases and complications. Recovery of bacteria in a density of at least 10 to the fourth power colony-forming unit per milliliter is considered significant. Plain radiographs. In the present era of CT, the role of plain radiographs are debatable. Radiographs show the presence of fluid or clouding of the sinuses. Completely opaque sinuses usually, about 85%, have pus in them, while 50% of sinuses that show thickened mucous membranes with central aeration have pus in them. Course. The following causes are considered in patients who fail to respond to appropriate antibiotics: tumors, granulomatous diseases, allergic rhinitis, and invasive fungal sinusitis in immunocompromised patients, and allergic fungal sinusitis. Computed tomography imaging and biopsy will confirm the diagnosis. Patients with recurrent acute bacterial rhinosinusitis are evaluated for predisposing factors, which include anatomical abnormalities, especially of osteometal complex, immunodeficiency, allergies, irritants, and cystic fibrosis. Recurrent acute bacterial rhinosinusitis cases need endoscopy and culture and sensitivity of the sinus nasal fluid. Differential diagnosis. Mucocele and neoplasms of the sphenoid sinus. They clinically mimic features of acute sphenoiditis. They should always be excluded in any case of isolated sphenoid sinus involvement, which is rare. Diphtheritic rhinitis. Diphtheria, which is rare these days, may be primary or secondary to falcial diphtheria, a grayish tenacious membrane, the removal of which causes bleeding, covers the inferior turbinate and the floor of the nose. Excoriation of anterior nares and upper lip are present in some cases. Treatment consists of isolation of the patient, systemic penicillin, and diphtheria antitoxin. Irritative rhinitis. It's caused by exposure to dust, smoke, or irritating gases, ammonia, formalin, acid fumes, foreign body, and intranasal manipulation. Patient develops an immediate Carter-Hall reaction with sneezing, rhinorrhea, and nasal congestion, which usually pass off rapidly with the removal of the offending agent. The symptoms may persist if nasal epithelium has been damaged and the infection supervenes. Treatment. The reasonable strategy for many patients is to treat symptomatically and recommend antibiotics only if symptoms do not begin to improve. The incidence of severe complications and progression from acute to chronic rhinosinusitis is extremely low. If the symptoms are severe or worsening, and clinical suspicion of acute bacterial rhinosinusitis is high, include antibiotics in the treatment regimen. Antibiotics. They have not been shown to decrease the risk of complication or progression to chronic bacterial rhinosinusitis. Expensive antibiotics are rarely prescribed when equally effective, and less expensive alternatives are available. The first line of antibiotics for uncomplicated acute bacterial rhinosinusitis are amoxicillin and trimethoprim sulfamethoxazole for 10 to 14 days. The course may be extended to 3 weeks in cases of partial improvement. Amoxicillin, 40 milligrams per kilogram divided twice daily, 500 milligrams 8 hourly, or 875 milligrams 12 hourly. Trimethoprim sulfamethoxazole, 160 milligrams per 800 milligrams 12 hourly. First-line alternatives, only for patients allergic to both first-line antibiotics, are doxycycline hyclate, 100 milligrams 12 hourly. Azithromycin, 500 milligrams daily for 3 days. Cefuroxime acetyl, 250 to 500 milligrams 12 hourly. Cefdinir, 300 milligrams 12 hourly, or 600 milligrams daily. Others, clarithromycin and cefprozil. Second line of antibiotics in cases of first-line failure or severe symptoms, suspected complications, and resistance. Combination of amoxicillin and clavulanate, cefpodoxime, and cefuroxime, have activity against beta-lactamase-producing bacteria and resistant Streptococcus pneumonia. In adults, fluoroquinolones are also recommended. Amoxicillin, high dose 875 to 1000 milligrams 8 hourly. Amoxicillin, clavulinate, potassium 825 over 125 to 2000 over 125 12 hourly. Levofloxacin, 500 milligrams daily. Intravenous antibiotics in cases of complications. For suspected penicillin-resistant pneumococci. Cefotaxime, 50 to 75 milligrams per kilogram per day in 4 divided doses, with or without vancomycin, 40 milligrams per kilogram per day in 4 divided doses. Then, antibiotics based on the report of culture and sensitivity of aspirated fluid from the sinus must be started. If needed, subspecialty consultation and surgical drainage must be considered. Metronidazole. In cases of anaerobic organisms seen in sinusitis of dental origin. Adjunctive therapy. They are not well proven, but do give symptomatic relief and include nasal steroid spray. For recurrent acute rhinosinusitis or acute rhinosinusitis superimposed on chronic rhinosinusitis, addition of the following high-dose nasal corticosteroids for 3 weeks may decrease the duration of symptoms and improve the rate of clinical success. Flunisolide, 25 microgram per spray, 8 sprays, 200 micrograms, each nostril, 12 hourly. Mometasone furoate or fluticasone, 50 microgram per spray, 4 sprays, 200 micrograms, each nostril, 12 hourly. Oral and topical decongestant. Nasal decongestant drops, 1% ephedrine or 0.1% xylo or oxymetazoline, not for more than 5 days because of the potential for rebound congestion and development of rhinitis medicamentosa. Steam inhalation alone or medicated with menthol or benzoin is done 15 to 20 minutes after nasal decongestion, hot fomentation, and analgesics. Surgery. The surgery is reserved for patients with threatened intraorbital or intracranial complications. The reported success of endoscopic sinus surgery is about 80 to 90%. It's indicated in the following conditions: persistent disease despite medical therapy, recurrent rhinosinusitis with identifiable and related anatomical or acute pathological abnormalities in the osteometal complex. Empyema, which does not respond to antibiotics, needs surgical drainage. Endoscopic sinus surgeries are successfully employed in managing empyema of paranasal sinuses. Antrum puncture and maxillary sinus empyema. Decongestants combined with xylocaine 4%, nasal packing cover mucosa of middle and inferior turbinates and middle and inferior meatuses. Inferior meatus antrum puncture with trocar and cannula is done. The purulent secretions of the maxillary sinus are displaced with normal saline irrigation. The mucopurulent secretions flow out through normal maxillary ostium. Children will need general anesthesia. Trephining for empyema of the frontal sinus. It's done through an incision on the medial part of the upper eyelid. It exposes the floor of the frontal sinus, the bone of which is removed with a cutting drill. A plastic catheter is inserted and fixed. The pus is collected for culture and sensitivity, and the sinus is irrigated. And the sinus is irrigated with normal saline 2 or 3 times daily. The patency of the frontal nasal duct can be determined by adding a few drops of methylene blue to the irrigating fluid, and its exit can be confirmed in the nose. Drainage tube is removed when frontonasal duct becomes patent. Empyema of ethmoid or sphenoid sinuses also needs surgical drainage, which can be performed either intranasal or external approach. Sphenoethmoidectomy. That's all for the video. We'll see you next time.